It's my pleasure to introduce you to Dr. Keri Donaldson. Dr. Donaldson is from Hershey, PA. He earned his MD from Temple University and his MSCE from the University of Pennsylvania. He is currently an associate professor of biochemistry and molecular biology with dual appointments in medicine and public health at the Penn State University in Hershey, PA. Dr. Donaldson is also the director of the Clinical Trials Processing Laboratory and the CLIA Laboratory in the Institute of Personalized Medicine. With a major research interest in clinical pharmacoepidemiology. Wow.
That's about right.
That's a mouthful. Dr. Donaldson is currently involved in the development of multifocal pharmacological algorithms to predict response to the therapeutics, multimodular characteristics of disease, including acute leukemias, and quality-centric decision support to leverage the EMR to optimize patient care. So Dr. Donaldson's topic today is making more informed decisions through the use of the immature platelet fraction. Welcome.
Thank you so much. And that was incredibly boring and long, and I apologize for that. I really do. I'm going to have to cut it down quite a bit. As they said, I'm from Hershey, Pennsylvania, which really is the sweetest place on earth if you've never been there. We make chocolate. It's the largest chocolate factory in the world. You walk outside, and on a summer's day, it smells like either Reese's peanut butter cups or Hershey chocolate bars. So if you've never been there, that's my plug for my hometown. My talk today has nothing to do with the vast majority of my introduction, but it does have something to do with this little icon, and I don't think it's coming up on the screen, or my laser pointer is not coming up on the screen in the top right-hand corner. What that is the Center for Quality Innovation, and that's where we, as pathologists, make advanced decision support in the real-time practice of clinicians. So if they're ordering tests, some of which we're going to talk about today, they can understand the relevance of it and it can drive patient care forward. We spend about 30% of our time doing that, and it's highly valuable to our institution. So one of my disclosures is that I am receiving an honorarium from Sysmex for today's presentation. And what we're talking about today is IPF and how we can use that to determine the differences in between different types of thrombocytopenias, what are the causes, and really, at the end of the day, what is the interpretation from this test. Platelet counts, depending upon your institution and the patient population, are defined as normal in between 150 and 400,000. That means somebody's thrombocytopenic if they have a count below 150,000. Is that clinical? Not so sure, and that's one of the things that you can try to determine with an IPF. The mean platelet volume is another parameter that you get off of automated hematologic analyzers, and something that can be fairly useful depending upon let's say, the aficionado that would be reading what a mean platelet volume is. They may understand that a normal is in between 9 and 12. Immature platelet fraction in adults, and this is something important to understand in adults, the reference range is normally is 1.1 to 6.1%. Why do we care? So if someone's thrombocytopenic, why do you possibly care? The reason you care is that can lead to, it can either be a symptom of underlying disease processes, or it can lead to clinical outcomes that could be fairly serious for the patient population. Some of the questions that a clinician may have as soon as they're looking at a platelet count that's less than 150,000 is this an issue with production? If so, is it a bone marrow process? Is there a myelosuppression caused by a medication, or is there a possible infection going on? Another common cause of a thrombocytopenia, I guess the second most common cause in a hospitalized patient population, depending upon your distribution of your patients, would be consumption. Number one here is actually not on the list. Who knows the number one cause of an increased consumption in platelets that you tend to see? It can be something as ubiquitous as a fever. So somebody that has a fever and is very sick actually can have an acquired thrombocytopenia. Autoimmune, autoimmune, medications and infections, fever being under infections. Number 4 on the list, or 3 on the list, from working down the most common causes in a hospitalized patient population of thrombocytopenia, you want to think about sequestration. Commonly missed on a primary exam, but will be picked up on imaging. Splenomegaly is one of the primary findings on imaging or secondary exam. Another concern, specifically if you have a large trauma center, is if a patient population comes in, they have an expanded volume and they're not transfused platelets, you can see a dilution of thrombocytopenia. So all these things are very important, and none of them are really apparent in the underlying lab value. So if you get a platelet count back, you know they're thrombocytopenic, but none of the questions that I just asked or the different clinical outcomes or diseases are apparent in the laboratory value itself. What does that mean? It means we as clinicians or laboratorians have an opportunity to improve the communication of the significance of that result. How do we do that? One of the things we'll talk about in a second is IPF, but really, how do we use our information to allow the clinicians to separate, bin, if you will, and probability binning is something I'm not going to get into today, but basically determine the difference in between a destructive disorder or a production disorder in a patient population. And this is important because, again, depending upon the presentation, this could be an acute myeloid leukemia, this could be a ITP, it could be TTP, it could be a bone marrow transplant issue, which is interesting for engraftment studies. It could be different types of neoplasia causing a thrombocytopenia because the metastatic disease has replaced the bone marrow itself. And none of these, again, by definition, are answered with a single platelet count. Luckily, we can help with an IPF. So what is IPF? IPF is merely the immature platelet fraction. I think of it, and it's in parentheses or parenthetical there, very similarly to a reticulocyte count. So you're looking for an immature platelet, and then you control that for normal in terms of the total platelet percent in that patient's body. The percent of platelets newly released from the bone marrow will have a higher concentration of RNA. The reference range in an adult population is 1.1 to 6.1. A common question is, what is it in pediatrics? And we'll get to that in a minute. IPF really is just a direct measurement of thrombopoiesis, i.e., I'm going to go back one slide. Do they have a production issue or do they have a destructive issue? So in a production issue, you would expect a lower IPF, and in a destructive issue, you would expect a higher IPF. So moving through it, what does it look like on the analyzers that are sitting behind me? This is a scattergram of an IPF and a platelet channel. And you'll notice that you have two distinct areas, one containing the IPF platelets and the other the normal platelet fraction. Moving forward, how do we interpret those results? So you're going to get a relative percent or an IPF fraction. What we're trying to answer as we started this conversation is, what is the cause of that thrombocytopenia? A few slides, a ton of diseases, different treatments, and different additional diagnostic pathways depending upon the cause of that. And really, what they're trying to figure out is decreased production versus increased destruction. What I would say, and again, there's a reason these are all underlined, is this is what you're trying to communicate to your provider or your ordering physician slash clinician. And acutely, what they're thinking about in green here is whether that patient has something that needs to be immediately managed, right? So decreased platelet count. Certain diseases need to be almost immediately managed or you're going to have increased morbidity and mortality. Top of your list, right? TTP, DIC. Probably everyone sitting in this small theater has seen patients with those diseases die pretty quickly. I've seen them missed, okay? So thrombocytopenia from a production issue, all right, maybe you can watch for a day. Maybe it's a holiday weekend. Maybe it's not going to be that important until Monday morning, right? Somebody comes in acutely, if you're at a tertiary care hospital and they've been transferred because they have TTP or NDIC, and you don't flag that appropriately either with this parameter or another one, unfortunately, bad things can happen to those patients. Hopefully, you would pick that up with other studies, but not necessarily. And that's one of the reasons to pay attention to your IPF. Another important clinical question that people miss sometimes is the second one that's highlighted here. If you're talking about engraftment studies, just like reticulated hemoglobin, if you're thinking about reticulated hemoglobin, IPF in a person who's transfusion dependent can be an early predictor or marker of engraftment of that patient's bone marrow transplant. So if you're following it over time, that's something to watch for. Whether that's clinically relevant or not has to be made, that decision has to be made in consultation with a physician, but if they're an informed end user, and they see an IPF coming back up and it was formerly 0, that can be an indication of early engraftment. And then the next question is, what other test, if you have an elevated or decreased IPF, would you be thinking about in terms of pathophysiology? That's a good question, and we're not going to get too much into it today, but it's really disease-specific, TTP, DIC, ITP. In those settings, you're going to go through and perform additional tests. If it looks like TTP, which is the scattergram furthest to your right, TTP, Adams TS13, you want to start plasmapheresis or plasma exchange pretty quickly. DIC, clearly there's additional labs that you want to pretty routinely look at. Autoimmune thrombocytopenia, specifically in children, that's something that you want to be acutely aware of. On the left-hand side of the screen, what we have is a scattergram again, and even within 5 minutes of seeing these for the first time, maybe you understand that they're markedly different, right? On the left-hand side of the screen, the low platelet count in a normal IPF is consistent with a production disorder. That may make the clinician not necessarily order additional laboratory tests, but have additional diagnostic assays vis-a-vis radiology or bone marrow biopsies that answers that question for them more quickly than if they didn't have this information. Now we're talking about what is normal, right? And so there's different slides, different studies that talk about what is normal in terms of IPF and thrombocytopenic patients. And in general, this is one of the studies that was used in 2006 to derive normal mean values in healthy patient populations versus patients with different disease states. In my hospital, we do not go through and categorize these different disease states, but it's important to know when you're looking at the screen underneath that mean column that the actual different diseases, which are your rows going down, the different types of destruction, different types of recovery, have significantly different, column furthest to your right, mean IPF counts. So an informed user could look at an IPF and say, is this most consistent with DIC or ATP versus a patient who has cancer or myelosuppression for drugs? There's a lot of granularity in this data that you can start to tease out. The first step is understanding what normal is and also reporting an IPF to begin with. Another question, and this highlights one of the other early points that I made, is how well can IPF help the clinician predict marrow recovery, status post peripheral autologous HPC transplantation? And one of the things to understand here is it's really patient dependent or individualistic in terms of engraftment studies. And one of the things that they're watching for is really just red cell counts, platelet counts over time, and trying to determine if this person is engrafting and what they should or shouldn't do for different types of transplants, tandem transplants, donor lymphocytes infusions. This stuff can be clinically relevant in those settings. What this basically says is, yes, a decreased IPF or a high IPF predicts engraftment. Low IPF either predicts failure in the setting of thrombocytopenia or lack of engraftment at that stage. All of those things are clinically important for this patient population. Moving forward, very similar information trying to determine what the differences are or aren't in terms of platelet counts and ITP, and really what the take-home message from this slide is the platelet count and platelet size. Platelet count not so useful to distinguish in between ITP and AML versus MDS. The platelet size, depending upon if you follow that parameter, can or can't be useful. But what I will tell you is immature platelet fraction definitively is, and that's the bottom right-hand side of your screen. So that's something that if you're trying to determine in between these two decisions, very quickly you can get a clinical indices that matters. So IPF and age range, a very common question. Children are not just little adults. It's commonly said that. So anytime you're launching these types of tests or normal ranges, I strongly suggest look at what they are in your pediatric population. You may not have to split it out in between, 1 hour and 1 day and 1 week, 1 week and 1 month, 1 month and 1 year, like some people do. But you at least want to ask that question. in particular when you would have reason to believe that these patients, being pediatric patient population, would have a productive deficit. So we went through and did this study at our institution, and we saw and we got as many as we could of healthy children, which again, getting a platelet count on a healthy child is somewhat counterintuitive, right? So defining exactly what a healthy child was a little challenging. The age range of this patient population was in between 0 and 89 days. The average IPF was 6.9 with a standard deviation of 4.5. Given the large numbers, that in fact is actually different than what our adult normal range is in our population. That means if I was flagging adult elevated IPF versus pediatric IPF, I have different numbers. It's also notable that it's not normally distributed, so this is just a frequency graph. Can anybody guess why that is? It's okay, I can. So the reason why you're seeing heterogeneity in these populations most likely is that primary patient population that I defined is in fact different. You see that the age range spread from 0 to 89 days. The ones with a higher platelet count most likely were a sick patient population that had a reactive thrombocytosis sometime, and we were able to separate that out. And these outliers greater than 10 fall out pretty easily. So in summary, IPF is a direct cellular measure. Think of it like a reticulated platelet count, which is really what it is. IPF is elevated in disorders of destruction. The marrow is producing more platelets. It's not a productive issue. IPF is an early indicator, although not the earliest indicator of marrow recovery. Is something that's important, specifically if you don't have a reticulated hemoglobin present in your institution. And IPF is normal or minimally elevated in marrow suppression disorders such as aplastic anemia and liver failure. What is my big take-home message? You should be reporting out IPF. If you're not, you need to do it. It's fairly intuitive. You set a normal range in children, and other than that, it's something that can be really meaningful to your clinicians. And at that, I will take any questions.
Anybody have any questions for Dr. Donaldson?
So yeah, that's a good question. So sepsis, what would you expect to see in sepsis? You want to answer the question, or you want me to answer it for you? Because it's, yeah. So a sepsis alert. So that's a good point. So do people use this in a sepsis alert? I haven't seen this in a sepsis alert. You would expect to see an elevated IPF in sepsis. You would not expect to see a bone marrow failure in most sepsis. I haven't seen them incorporated as part of sepsis alerts, but that would be interesting to model, because many hospitals do sepsis alerts, and you're running this parameter on any patient population that's going to have sepsis anyhow. It'd be pretty interesting. Any other questions? Thank you all for your time and attention. I'm available after the talk for questions specifically.
Correct. Right. Do you want to, she's asking about how you set your own reference ranges.
Range. That's a good question. I had a talk yesterday on reference ranges. I don't know if you were there, but you look pretty familiar. So you would set your reference ranges in this setting. This is an in vitro diagnostic. So you can go through and help, the manufacturer will help you set your internal reference range. I would also suggest confirming that in your patient population. The number of samples that you can use, again, try to take normal patients. What does normal patients mean? That's always a challenge in a hospital. It's one of the things that we struggle with. Try to take normal patients, define them as you would a normal patient population, like exclude leukocytosis, exclude anemia, and try to take that patient population as being normal. It's about as close as I can get you right now. Take adults greater than 18 years old, and then run a fair amount of these samples. Given it's an IVD, 50 is more than enough, honestly. If you were going through and adding a new parameter, you would want to increase that number above 110, really to 120. But in this setting, given that there's strong data and strong research to suggest what that is in adults, I would want to go through and just confirm it with 50.
What about for children, she said?
So for in children, that's exactly what we had to do. So if you're going to report this out in kids, we don't report out a reference range until we do those internal studies in children. So you either put that as a comment on your report that this reference range is validated in adults, not to be used in children, excuse me, or you go through and do your children's study like we did and say this is where I think it is. There's not a ton of data on a normal reference range in kids. And there's a reason, because again, it's heterogeneous, and getting samples from healthy neonates is a challenge, right? And even if you have a children's hospital like we do, it's still a challenge because they're in a children's hospital for a reason, right? Yeah, not like adults where you have a significant outpatient population. Any other questions? Sure. It's a good question. Or stability is another good. Yeah, that's a great question.
Platelet clumping and specimens.
Yeah, so one of the challenges in this, and we can get to platelet clumping in a second, because really, hopefully, you pick that up with a flag, right? There's ways that these analyzers flag platelet clumping. One of the more important questions with IPF is sample stability, and I think that's something that you have to be aware of, because platelets are not fixed at all. In fact, if you take a platelet and put in a very micro well and watch it over time, sometimes platelets divide. Sort of blows my mind a little bit, right? Because you think a platelet count shouldn't change, but it really does. And what I'll tell you is if you have samples around for a long amount of time in preservative, sometimes that IPF number is going to change. So you set those performance characteristics at your institution depending upon your collecting media and how you're doing it. So heparin versus EDTA, how you're transporting your tubes, whether it's a centralized lab, it's getting everything from the hospital. You also want to go through, and if you have multiple analyzers within a hospital running this in different ways, you want to make sure you do really good concordance studies. We found that up to 4 hours at least, this is a fairly precise measurement dependent upon how the collections are done. If you have this sample shipped, in a warm van on a summer's day and it lasts the weekend, that's probably not something I would want to go through and run, because again, we're talking about RNA in platelets, cooked. It's something you want to think about. I would do the study. The best way to answer that question is you go through and you do pairwise comparisons. So you take a patient sample, you split it, you let one sit, run it after a certain amount of time, and you see if that IPF changes. It's exactly what we did. Ours didn't, but I don't want to go through and make that assumption in your system without knowing all the individual variability. And it's a really quick correlation that you can do. And you can draw a healthy volunteer and do that. Just take 2 tubes, let one tube stay, have the other one ran immediately, and you can talk about whether that changes. And then the next question, your follow-up question, is how much of a difference actually matters, right? Yeah, so how much variability do you find is clinically significant? And that's something that a medical director has to talk about. I wouldn't be worried about anything less than 20%. Any other questions? Thank you all for your attention. I deeply appreciate it.